One of the really nice things about running the Center on Aging is, to use a sports analogy, the amazing roster strength. Just the incredible number of very established and senior investigators that currently work here. It was one of the reasons I came back in 1992 when I was looking at jobs. There just weren't a lot of people studying old people back in the old 90s. And UTMB, this little medical school on an island in the Gulf, had Kyriakos Markides, who was internationally recognized as a study of older Mexican Americans. It had John Papaconstantinou, also with international reputation in cell biology, and Tom Cole, who was just a wonderful historian of aging. And so that was really the major reason I came. And then soon after I got here, Dr. Gene Freeman, and then a couple years later, Dr. Ken Ottenbacher came, and there was just then a whole bunch of us senior people. And then what really nice happened is that we grew our own over the next really 20 years, so that people who came as fellows or as assistant professors, you turn around and 10 years later, and they're this full professor with an international reputation, and they even have a distinguished named chair that they're holding. And so Elena Volpe came as a fellow in the late 90s, and now she's a distinguished chair, and she runs our Pepper Center. Tony Denuzzo came as a graduate student, and now runs the Geriatric Education Center. Mikhailo Raji came as an assistant professor back in the 90s, and now he heads the Geriatric Division. Gulshan Sharma came as a junior faculty member around 2000, and he runs the intensive care unit now and has a distinguished chair for his outcomes research. And Taylor Ryle, who came as a junior faculty at about the same time, also has a distinguished chair, and she's a surgeon, and she studies older people and how they undergo surgery. So it's really an amazing group. And what that means is we have a tremendous bench strength, which brings me, and it means, like in the case of an emergency, you can just turn around and you've got like 10 people who can do something, who are adults, who can do something, who are, they've done it before. Which brings me to the topic of our current lecture, which is our visiting lecturer tonight finked out some silly thing about storms and flight cancellations, and so wimp. Easy to say in Galveston, but where was she from? Baltimore. Okay, so they got all, Southwest canceled its flights from Baltimore to here today, and so we did not get a chance to spend the day with her. But because of our incredible bench strength, we have Rebecca Wong, who's going to be talking on a related issue tonight. Dr. Wong was born in Mexico, in Matamoros, and she went to college at the Autonomous University of Mexico in Mexico City, the big national university there. And then after she graduated, she went to the University of Michigan, where she got a PhD, a master's, and then a PhD in population economics. Population is important because it means that she's a demographer too. She studies populations, but then she also studies economics. She is currently, well, she did a bunch of things afterwards. She was at Johns Hopkins for many years, and then at the University of Maryland for many years, flitted around at Georgetown University also, all in that sort of same area. And then we convinced her, after probably, I think, about a 4-year courtship, to come out and join us in Galveston, because then she would really overnight sort of double our strength in studying Hispanic aging. And what we dangled in front of her was the Peaches and Shrub Kempner Distinguished Professor in Health Disparities, which she's held since she's gotten here. She will tell you about her research, which is famous. She directs our WHO, World Health Organization, Pan American Health Organization, Center for Aging and Health. This was created, another thing that we created to sort of dangle in front of Rebecca to get her out here. And it is one of, I think, only 8 WHO centers in the world on aging, and it's the only one in North America. And so and we got it essentially because we have this incredible bench strength. So thank you, Rebecca, for filling in at the last minute.
Thank you very much. I think you can hear me with this mic. Okay, he said I can use this one too, but then I think it's an overkill. I think I'm okay. Thank you very much. It's a pleasure to talk about our work, our research, and the reason why I said ours, because now there's lots of people in the campus who actually collaborate with me in this work, and researchers around the world too, as I will. So, a brief outline of what I'm going to do. First, I'm going to try to motivate you of why we need to study Mexico. And this is what I do. This is what I do when I ask for money, right? We ask for money, and the first thing you want to say is why. Why is it important? And then I'll describe the study, brief results of the latest wave of the study, and then the position that the study places or has in the global study of aging. I hope to show you that it's a pretty neat study and has a lot of sisters out there. Why study aging? The population 60-year-olds of 60 and older in Mexico has gone up, as you know, from many countries in the world. Right now represents about 10%, 9% in 2010 of the total population of Mexico. It's not a very old country compared to the United States, for example. But it's aging, and the reason why it's peculiar or important to study it is because it's aging very fast. So the proportion of the population was 6% in 2010 and will be 15% in 2036. So that's about 26 years to go from 6% to 15%. How does that compare to the time it took other countries? United States took 69 years to go from 6 to 15%, and it reached it in 2013, last year. France took 115 years to go, same thing, from 6 to 15, and that was achieved in 1980. So this is happening, and it's happening very fast. It's not unique to Mexico. This is very common in Latin America right now. This is what's happening to many other countries. Just that the speed is too fast for the level of economic development that the countries have. And we had not seen this kind of speed. Now, where does the speed come from? Just as a demographer, a quick note. It comes from the speed at which mortality fell and fertility fell. It took a long time for mortality to fall in France and the United States compared to Mexico and other developing countries. It took a long time for fertility to drop in Europe. But once we knew about family planning and how to distribute it, then it was very fast. The propagation was very quick in Latin America, and it's been very quick in Africa. And so the aging of those countries is also going to be very fast compared to how developed countries aged. So these countries are aging fast and also are doing it in very low socioeconomic development. Again, Europe, Japan, those countries aged in that speed that we saw, and when they reached the 15%, they were much more developed, socially and economically. So this is a complete new kind of scenario for the world. We've never seen this speed, and we've never seen aging in this level of economic development. In addition then, what we have is a very strange pattern that we had not seen in developed countries. The people who are current elderly in these countries like Mexico and other countries in Latin America, they are survivors of very infectious, very highly infectious regimes. When they were children, there was polio and there were other diseases that killed children, but they survived them. And so when we see it's a very special group of people. Again, when developed countries age, the ones we're talking about, they did not survive. The ones that are old right now in the United States, in France, in Japan, they were not born under these infectious conditions. And at the same time, then, in the same life cycle, these people survive infectious diseases, but they are going to get the chronic conditions of developed countries. And so heart diseases and other chronic conditions are going to be in the same body that survived those infectious diseases. So when you think about it, we haven't seen this in the human race, and it's the new kind of aging, what we call the new kind of aging. This mixed regime, when we say the same people had infectious and chronic conditions, it's going to be very different, like I said. And so we don't know what kind of aging this is, how it's going to manifest. So in old age, these people who survive infectious diseases, are they going to be stronger because they're the survivors? And so they should be able to manage chronic diseases better than what we see in developed countries? Or are they going to be weaker because the blueprint of what happened to them in childhood will be leaving them weaker? And so we don't know if they're going to be more disabled, if once the chronic conditions set in, they're going to be more unable to overcome them, or what's going to happen to them. So this is the stage of which we arrived in the late 1990s, now that Jim was talking about history. We arrived in the 1990s and said, this is going to happen. As demographers, we know what's coming, right? In many of these things we can predict because fertility dropped fast, because mortality dropped fast. We know that aging is coming very fast. And so when we see this, we think, then we had to approach, at that point in the late 90s, we approached the NIA and said, we need to start studying these countries as well, and not just the rich countries. Also because Mexico has a very large, long history of migration to the United States, it became important to understand aging of Hispanics in the US, to understand the patterns of aging of the Mexicans, where most of the population is coming from now. So like I said, way in 1998, 1999, we started to think about launching a study of aging in Mexico. So we got together a few collaborators and we put together a prospective longitudinal study of aging in Mexico with the idea of replicating some of the studies that were taking place already in the rich countries, like, again, Europe and the United States. So we have a large group of collaborators. Now I'm at UTMB. The INEGI is the major collaborator in Mexico, is the Statistical Bureau of Mexico. Think of the Census Bureau, but bigger. Because in Mexico, they do all the censuses and they do major surveys. They do the national accounts, the photography of the country, the satellite images, all the geography of the country. And they also do all the vital registration of births, deaths, marriages. They keep track of all that. Like I said, national accounts and so on. So that's INEGI, that's our partner, and they do all the field work for us. The University of Wisconsin, the National Institute of Geriatrics in Mexico. When we started in the late 90s, the National Institute of Geriatrics didn't exist. And some of us think that actually the study I'm going to tell you helped to create that National Institute. The National Institute of Public Health is also one of our partners in Mexico, and the University of Pennsylvania in the US. We proposed to NIA to come up and learn about the aging patterns of the countries that are coming of aging, the coming of age of these countries, the countries that are going to age next. And we said this is very important not only for the global aging, but also for the aging of the United States. And we were financed. At the time, in the late 90s, the PI of the study was Beth Soto at the University of Pennsylvania. She's now no longer, she's retired. And then I took over. So what we proposed to NIA is to fund start one of those cohort studies where we would take a cohort of people, a representative sample of Mexico, and start following them to see how they age, what diseases they obtain, they get, how disabled they become, who helps them, who pays for their medications, their hospitalizations, who takes care of them if they become disabled, and so on. So we selected a sample of individuals of age 50 and over. And the reason why it's 50 is because we want to study the process before they start aging, before the major chronic conditions set in. At age 50 and over. And then with representation, as I said, national and in urban and rural areas. The data it's one of those very large epidemiological studies. Actually, our guest who didn't come today was going to talk about another large epidemiological study in the US, but this is one of them, except that this is in Mexico. So, and it has many purposes. It has health measures, economic measures, social, psychosocial measures. What we want to know is how you age, and that has to do with your diseases, your disability, but it also has to do with your family, where you live, who you live with, who helps you, like I said, who pays, how many years you work, in what were you working in, what are you working in, and how happy you are. This is the psychosocial aspects of it. How do you feel satisfied, and what makes you unhappy, and so on. Like I said, it's funded by the NIA. And we then asked, and these are, as many of you in the room know, these are 5-cycle R01s, types of grants. And so in 5 years, 5-year cycles, in 5 years we could fund 2 rounds of the study. So right away we said it would be a baseline and then a follow-up. There would be two waves. And we would have a variety of topics in the study. So these are basically surveys. You interview people in their homes. You arrive and you say, please, I'd like to interview you. We'd like to ask you many questions. So because we want to learn about the process of aging. So we asked about socio-demographic characteristics like your age, your marital history, your children, how old they are, where they live, who you live with. Health, multiple dimensions. We asked about chronic diseases, heart, stroke, lung, cancer. And we asked about diabetes, family and social networks. We talk about where are your children, the ones who don't live with you, how often do you see them? And migration, because it was a study that measured the relations between Mexico and the United States, we in Mexico asked them everything about their migration history, if they've ever been to the United States, if they're back, if they have children in the US, and I'll show you some of those results. Who helps them, who pays for their expenses, and who they help. And we see in the life cycle of people 50 and over that up to between age 50 and 69, they help a lot their children. After age 70, like a switch, they get helped a lot. Economic data, like I said, their work history, their retirement plans, their retirement pensions, what kind of occupation they had, if they have one now, and the conditions of where they live, the dwelling, and how they feel. I was talking about psychosocial aspects, the attitudes about health, about how poor or rich they feel, and how much power they feel they have to make decisions like going to the doctor or even their will, and so on. For those who are widowed, we talk about the widowhood, and as we're going to follow people, people are going to die, spouses are going to die, so there's a major interest in learning what happens to the widow and the families when a spouse dies. And this, of course, has a lot to do with a country that, like we said, is in very poor socioeconomic conditions compared to the rich countries. And so there isn't a universal social security in Mexico, there isn't Medicare, there isn't Medicaid. And so how do people cope with old age is going to be very important for countries, like I said, that are aging very fast and with very different socioeconomic conditions than the US and Europe and Japan. We also, like I said, talk about their children and subjective measures like satisfaction and how they perceive actually the help they receive from their children and the power that they have. And this is what the typical interview looks like. The interviewer sits there and talks to the persons for a while. And the information that we gather takes about 2 hours, an hour and a half in average, but really 2 hours to be in the household. And they love it, by the way. All their adults love to be interviewed. So what you have to do, really, you train the interviewers, and the training has to do with how to cut the interview, how to cut the answer, because they love that somebody comes and wants to ask about their life, how they feel, and so not many people, I guess, come out and ask questions, and they give you the Coca-Cola and the whole thing. They just love it. So at baseline then, like I said, we identified 11,000 households in Mexico that had at least one person age 50 and over. And we also interviewed the spouse regardless of the age. And that's because we want to know the dynamics of health. If one spouse gets sick, what happens to the other? And like I said, a lot about the widowhood. And we come back with about 15,000 interviews, 15,000 people to be interviewed. And like I said, the INEGI, the Statistical Bureau in Mexico, conducts the survey. Believe it or not, they sweep 15,000 interviews in 3 months. So they have, I'll show you where the samples are, where the sample is, and they have to go to the households, knock on the door, and interview people. So they obviously have the infrastructure in the country to do this kind of work, because that's why I told you what they do. They do everything in the country, right? They do vital statistics, they do censuses, they do surveys, they do geographic, so they have regional offices and so on. So we did a baseline interview in 2001, and then we followed the same people, and we go back to interview them in 2003, 2 years later. The proxy interview, so by the 2003, when you arrive and the person is dead, one of the people, out of the 15,000, by 2003, we had 540 dead. So we interview a relative, and we find out, like I said, about the last year of life and what happened to the wealth, what happened to the expenses, who paid for them, and so on. Like I said, about an hour and a half. It's a face-to-face interview. It's not by phone. Many of the surveys in the US are done by phone. And in 2001 and 2003, still, we did it paper and pencil. I forgot to bring, but the interview is pretty thick when you do it paper and pencil. Then in addition, we took a random subsample of around 2,500 of those 15,000, and we took anthropometric measures, meaning the height. You measure the height, the weight, the circumference of the waist, of the hip, of the calf, and they did a 1 foot balance. So the idea here is not to measure prevalence of anything, but rather to compare the self-report with the measurement. So with this subsample, we said, okay, we compare now what height he told us in the interview that he had and how much he weighed, compared to the objective measurement of height and weight. And so that was the objective. And a few performance measures. If he says that he cannot walk or he has difficulty walking, and then you see him being able to stand in 1 foot balance. So this is all about a methodological way of checking the self-report. Now, I said that we had a major interest on migration to the US, and we then selected an oversample in 6 states that represent about, those 6 states are typically sending states to the United States. And about those 6 states account for about 40% of migrants to the US. And for those of you who are wondering, why is it so far from the border? Don't you think that it would usually be the border where the migrants come from? But it's not. It's from those states typically because way in the 1940s, there was nothing in the north. It was empty. And the valley, the Bajío was actually with people. And there was a railroad that went from the US to Mexico. And the first community that had some people was Zacatecas and Durango right there. Those are the first states that you hit where the railroad went by and they could find work. So it was temporary workers, the Braceros program, where the US employers went down to look for workers, and that's where they came from. And so that's what it started, and then traditionally it became a network of migration. And so that's where traditionally they kept coming from that area and not the others. So we oversampled these states to try to find more people who had at some time been migrants to the US. This is just a scene of people being interviewed, and I don't know if you can see me, I'm the one with the sunglasses, and we are interviewing and visiting with this family in Oaxaca. And this is Mexico, the map, and where all the communities where we have sampled. We have sampled in all 32 states. There are 32 states in Mexico. And this is interesting because when we selected the sample at the baseline, they told us it's a little dispersed. Dispersion of the sample is good, for those of you who understand, for the standard errors of the estimates. That's good. But it makes it very expensive. Very expensive in the sense of logistics. You have to go to all 32 states, and then you're all over the place. But it turns out that it's good in follow-up, where if you're going to follow people. If somebody moves from Campeche to Baja California Norte, we're always going to have people in any of the states. If they move from one state to another, you just call the people in the other state and say, you got that one because he moved there. And so it's good to have. It turned out that in longitudinal studies, the more spread you are, the better able you are to follow people all over the place. And just to show you a little bit of the results we got, and we were looking at 16,500 individuals. We got a response rate of 91.8, 92%. And then we came back then with 15,186 interviewed individuals. And that all I'm trying to show you is the very high response rates. Then when we go back to 2003 and we're looking for these 15,000 people and the new spouses, if somebody married a new person, that new person becomes part of the study too, we added 125 people. And we got 93% also response rate of follow-up, which is also very good for this kind of study. And so when we look at and talk to our colleagues in the United States and so on, they always admire the response rates in countries like Mexico. It's not just Mexico, but countries like Mexico get very, very good response rates. Like I said, people want to talk to you, but also people don't move a lot. So being able to find people and 2 years later is not as hard as in the US. Sometimes they don't say, come in, and they don't give you the Coke. They let you standing in the door, and that's what this young woman is doing. So what's the timeline? We now have then the 15,000 that I told you, and then we went and found them in wave 2. And by then we had 540 who had died. And then there was a big silence in our study between 2003, 2005, 6, 7, 8, 9, 10, 11. I mean, nothing happened. Basically, our team disbanded. And Jim was telling the story. I came here in 2008. And so between then and now, we organized ourselves. In 2010, we decided we would like to go back and follow this cohort. So we got organized again, and we went back to NIA and said we'd like to follow this cohort. There are interesting things that happen in Mexico that it makes it very exciting to follow this cohort. So what is it? Well, there's a move to universal healthcare in 2003 and 4. And that means that we were there before, and we're going to go back after. And that gives a great opportunity for us to see what is the implication of, in this kind of society, aging and so on, when there's a move to universal healthcare. And so, and also there's a move in the 2000s to try to expand Social Security, because it was only available for those people in the formal labor market, and there was an attempt to expand. The health insurance has been much more successful than the Social Security reform, and so, but still, when we went back in 2010 and said we want to follow this cohort, we went back because we said we'd like to continue the longitudinal study, but also there are two major reforms that happened in Mexico. In addition, we all know there was an economic crisis that hit the markets of the world in 2008, 2009. So it made sense that we were going to be, again, before the crisis and after the crisis. And so there was a lot of interest in the economic world to understand what happens to people under those circumstances. Part of the way the crisis hit is that unemployment was very high in the United States, and people were not hiring. And so that meant that migrants from Mexico retrieved. And so at some point in 2010, the net migration, the people who were coming into the US minus the ones who were leaving, was zero. And I don't know if you knew that, but this is one of the reasons why it's very interesting to study this. So what happens when the migrants retrieved from the US and went back to Mexico? Many of the children of the elderly and so on. And so again, with all of these arguments, we talked to NIA again, and we presented ourselves and said, we want to go back and follow this cohort. So we got funding again, and we got, again, a 5-year cycle to study, to follow this cohort. And we're going to do two surveys in 2012 and in 2015. So we're going to follow this cohort, but we're going to add, which we did in 2012, we added 5,896 new people, because when we had a cohort of 50 and older, and we're going back 11 years later, most people are going to be, all of our cohort is going to be 60 and over, if the survivors, right? And so the 50 to 59 space got empty, so we filled that space with 5,896 people of that young age group. So now again, when we look at the cohort that we have, that they are once again representative of the people 50 and over in Mexico. And it's very exciting because in one of these cohort studies, what happens to people of these ages is that they die. And for us, mortality is the ultimate outcome that we want to study, right? We can predict mortality, what happens to people where they're frail, where they're disabled. And so mortality is a very important outcome. And we had, like I said, we had 546 dead between these two waves. But by the time we reached 2012, we have 2,740 who had died for a cumulative deaths of 3,300 almost. So when you start with 15,000 people and 3,300 died, this is enough to study mortality. And so for demographers, the only way in which we study mortality is with vital registration. So you go and look at the certificates of death, but that only tells you a few things, certificates of death. Whereas for this kind of study, we had a whole full interview with them about what they were doing in their childhood, in their occupations and so on, and their diseases, and now we know that they died and how they lived their last year of life. And so it's a very exciting, I know we don't want people to die, but it's very exciting to have so many deaths. So this is more images of people. Actually, in one of the batteries I didn't tell you, in health, we also measure depression and cognition. So there's a battery in which people actually grab a pencil and do certain exercises of cognition. And this lady right here is circling all the objects that look like that one in the left. She's supposed to circle all the ones that look like that in that page. And the interviewer is timing her. So we have several instruments. Like I said, there's a basic core questionnaire, but there's also for the people who died, there's a special questionnaire for the relatives. And there's the cognition battery that we present to people. And it's starting in 2012, the third round in this time. Now we moved every interview to be done by computer. Before I told you they had to do it paper and pencil. But now in this round, everything is by computer, except for the exercises that they do. They do it in a piece of paper, in a booklet, and they do that with their hands. Otherwise, everything else is done with copy these days, which means that the human error in interviewing is much lower, and also the speed at which we can get the data back and up is much faster. Because there was a silence there of, last time we went is 2003 and we went back in 2012, there was a silence of 9 years. We asked the major events that had happened in their lives in the last 10 years, and actually I'm going to show you some results of that. A lot more content of psychosocial, because the field had moved more into that kind of content. They want us to measure how happy they are, how lonely they are, how satisfied they are, and it's about a lot of the field, many studies in the field have moved to study that. And then we also included in that subsample for objective measures like we had done before, but in addition, we added blood sample. So we took blood. I'm going to talk to you some more about that, and a little bit more performance measures, objective performance measures. Since it's so expensive, it's complicated, and it's complex and hard to guarantee the quality when you take blood of 15,000 people in their homes, we selected only a smaller subsample to take blood. So one of the big questions we had that NIA had to trust us was, can you recontact these people? 9 years later, we had been there in 2003. So in order, when we presented the proposal, we had to present a pilot of recontact. We did a recontact of 200 cases, and we got a very good recontact. So then they believed us, I guess. And what happened was that when we went back in between 2003 and 2012, we were able to recontact 88% of people. Live or dead, we found 88% of people. Dead meant we can interview a relative. But this is a fabulous response rate after 9 years. I was going to be elated if we had gotten 70. But the guys from the INEGI Statistical Bureau were going for 90. And I just like, okay, go keep for it. But I was going to be very happy with 70. They came back with 88. So we're very happy. So we were able to recontact people either dead, like I said, so we interviewed 2,700 relatives. Proxy interviews are people who cannot give their interview directly because cognitively they can't, and direct interviews of 14,500 people. It's a major challenge now, though methodologically, for those of us who are trying to study trajectories, we have to grapple with the fact that there's a 9-year silence. But on the other hand, like I said, when you have this gap, then you have enough events like deaths happening, enough people who deteriorated cognitively, enough people who deteriorated physically, so we are able to study a lot of the transitions in diseases. Now, what do we do for that subsample? Like I said, we measured and so on, but now we're going to take blood. So what we decided to do is to take, according to the budget, we could cut it small or big, but we cut it very small. So the subsample we took 2,200 people who were in 4 of the 32 states. So the whole sample in 4 states are going to be measured and weighed, and blood was taken from them. And they did hand grip, and the National Institute of Public Health is our partner. They launched the operative that went out, and after the interview by the Statistical Bureau, then about a week or to 10 days later, the National Institute of Public Health came back in those 4 states, came back and said, okay, we're here for the health visit. And so what they do is they got finger prick, and so a little bit of blood that, you've done it, but puncture, and you get hemoglobin using HemoQ. And then you also get an idea of another prick, and you get circulating glucose. So we were looking at anemia and at diabetes. And they also got then intravenous blood, 2 tubes of one for, has a very specific destination and what they're consented to. We are going to get CRP for inflammation, CRP protein, total cholesterol and HDL cholesterol, thyroid hormone, and vitamin D from 1 tube. and from another tube where it's going to be stored for genetics in the future. This is part of a master plan that NIH has for the world. If we one day can study genetics very reliably, then all of us are going to contribute our samples from the different countries, and Mexico is ready to do that. So you see this person sitting down, ready to give blood. I'll tell you a little story. We went, and this particular person was under a walnut tree, and he said, okay, here is great. Okay. And then the neighbor came out and said, well, what about me? And so, well, you haven't been selected, you know, even for the survey. But you're taking the blood, yeah? And so, but what about me? I want to know. And we had to convince her that she had to go to the health center if she wanted to know. But, you know, please take this card and tell them that to do these tests, but we cannot do it for you. So just to give you the impression that they really like it. And in particular, the health visit. So I was impressed that for the health visit, they also wanted to be pointed and pricked and walk and weighted and measured and so on. And then, which is very complex to have a sample of blood taken in the house. We had to take the blood, centrifuge, take it to the health center, put it in a nitrogen tank. They took it back to one central lab in Mexico. So that's why we wanted to do it only in 4 states. So I'm going to talk a little bit about results very fast. And this is universal. Women report worse global health than men, even though women live longer. They apparently live longer, but not as healthy. This is the self-reported health, while women report worse health. Continues to be the case. We had found out in the previous 2 waves that's still the case. It's still also that the report of chronic diseases is higher among women, again, living longer, but not as healthy. Cancer, men, the exception there is stroke and heart attack, pulmonary disease, diabetes, arthritis, and hypertension. Women are more diseased than men. One of the interesting parts, like I said, is to study mortality. You're going to see that as demographers, again, we can estimate the expected deaths by applying the mortality rates of the country to a sample, our cohort. We knew how many expected deaths we would find. So we were expecting, sorry, that's in Spanish, the blue is expected by age, and the red is what we found by age. And so the mortality rates in the country then predict that we would find fewer deaths in old age than we found. And that's a well-known fact by demographers. The life tables are underestimating mortality at very advanced ages. But in the younger ages, the expected was a little higher than the observed. So that's just there for demographers to study whether we can study mortality better with these kinds of studies. And maybe there are people trying to adjust the life table for Mexico based on this kind of studies. Now, remember I told you about health insurance, so we were curious to see how much we were going to find in health insurance change. Indeed, the population in Mexico of this age had about 50% of them have health insurance in 2001, 2003. By the time we went in 2012, 80% of them have health insurance. So there had been a major change in the coverage. And the majority of the change, it was here. This is the group. The first set of bars are people who had health insurance both before and after 2001 and 2012. The purple is the urban areas, and the green is the rural areas. So as you can see, people who had insurance in both decades, to call it that way, are mostly in urban areas and much lower in rural areas. But the second set of bars, the one with the circle, is those who didn't have health insurance in 2001, but they had it by 2012. And that's, again, the green bar is the rural. So the majority of the gain, health insurance coverage, is happening in the rural areas. which is a good thing. The third bar is those who had health insurance in 2001 but then lost it, perhaps because they lost employment or a widowhood. And then those who had no health insurance in both decades are the last set of bars. So there's going to be a lot. We are already presenting some of the papers that evaluate the impact of the health insurance scheme in meetings in May. But there's going to be a lot of interest on what diseases in particular, what health behaviors in particular are going to be impacted by the new health insurance scheme. In ADL, women report activities of daily living. Women report more difficulties. Again, it's a very well-established fact, but we are able to study the dynamics. How does it change? Which ones develop first in time? Like I said, we talked about their impressions, and in general, either the older adults are very knowledgeable, or they just tell us yes when we need to know, to get a yes. We ask them if they think it is possible to improve their health by controlling their own habits, like eating or stopping smoking, and say, sure, yes. And so they believe that that's the case. They also have beliefs like they have a positive view of life. They are satisfied with their life, a majority of them, 80%, men and women. They said they have acquired things that are important in their lives, 80%, and that their lives are close to ideal, about 71%. They also contribute a lot. We include a time use, about 12 questions on time use, and we can see that red is women, the blue is men. Women do a lot of housework as expected, but they also take care of a sick or disabled adult, both men and women, about 20% of women, 15% of men. And they also take care of children, 30% of women, 17% of men. So they contribute, as we said, to their families and the economy. In this particular question, when we asked them, remember about what happened in the last 10 years in your life? We asked them about different things, like somebody died in your family, your spouse, a child. Did you have to move? Was there a major natural disaster? Were you a victim of a crime? And we looked at the patterns of reporting, and they don't report always like in the lower picture where you would say, oh, 2001 to 2012, the more recent is higher, perhaps because they remember. But it turns out that they don't report it always that way. So there has been an uprising in crime, as we know, both because of the unemployment in the world, but because a lot of migrants went back from the US to Mexico, and we think they're unemployed, but of course of the gang and the drug cartels crime in Mexico, so they are reporting an increase of being victims of crime in the recent years. But if you look at, have you been victim of a natural disaster so that your house suffered a major impact? I was thinking of Ike. But you know, they're reporting all over the place in the years at the top from 2001 to 2012. That's the frequency of reporting. And so there's this 2007 peak, and we went to see what had happened in 2007. And indeed, there had been major floods in the southeast of Mexico in 2007. And that's probably why that went up. So we are, methodologically, we're happy with the answers to this recall of the 10 years. Now, this is one of the most interesting facts or findings that we have, and that many people find interesting. So when you ask the respondents if they have been migrants to the United States, or if their children have been migrants to the United States, it turns out that 14% of men of 50 years or over in Mexico have been migrants to the United States. And the question is asked as you worked or lived in the United States, not went to visit, but was a migrant. And so 14% of men. And 30% of men say that at least one of their children at some point was also a migrant. So it's a lot of interaction between the two countries, And we thought it was, but we found it. And also that means that there's a lot of remittances that are sent from the children to the parents. So aging is supported a lot by the US. And this is what happened between 2001 and 2012. We were curious to see if their children had retrieved and are no longer in the United States because of what I talked about, the financial crisis. But we find enough, and this is MHAS in 2001, this is in 2012. And this is the proportion of that report that they have at least one child as migrant in the US. And that's the red is, yes, I have at least one child. So 21% said that I currently have a child in the US, and 29% said they had ever had at least one child in the US. By 2012, that has shrunk a little bit, but not a lot. 17% said that they had a child in the US, and 32% said they had at least ever in the US. So that is sort of what we expected, a little bit of a retrieve, but it's not obviously a lot. So there's a lot of, still for us, a lot of variance that we are going to study. What happens to remittances and loneliness and stress over what happened to your children and so on. Now I wanted to show a little bit of the transitions that we can study with this kind of work. This is the transitions in physical and activities of daily living limitations, whether you can do or have limitations like bathing, eating, going to bed, using the restroom, or dressing by yourself. And it turns out that this is what happens over 2 years. When we looked at in 2001, so people who had 0 limitations in 2001, by 2003, 82% still had 0. In 2001, if you go here, if they had 3 limitations, by 2003, 28% of them actually had died. The green is the deaths. And so the more limitations you have in 2001, the more likely you are to be dead by 2003. So this is what happens 11 years later. So this is where you were in 2001 and how we found you in 2012. When you're 60 and over. So if you started with 0 limitations, by 2012, 31% were dead, 42% still had 0 limitations, 11% had 1 or 2 limitations, and so on. But see, if you had 3 limitations in 2001, 61% of them had died by 2012. So again, the ADL limitations seem to smoothly progress to death. And the last part is the people that we lost to follow up. So there's a lot of interest in following the progression of disability, and this is work that we're doing with Tim in Rise to Terror in the audience, and Carlos Diaz-Venegas, our postdoc. And so in this kind of models, then now we have 11 years. If you look at this trajectory of 11 years, you see these are females and these are males. So we can actually construct what happened in those 11 years. And this is the probability of the number of ADL limitations that you get by gender. And so you progress in this kind of pattern. And we are very excited about being able to inform the progression, because that's what happens again when you have a long panel, that you can be in 3 points again, also because that gives us the ability to estimate how people are, what trajectories they're following. And of course, there's a very tight relationship between the disease trajectory and disability trajectory and schooling in Mexico. Still very vast inequality. Inequalities are widening, not narrowing, and also, which is also true for the US, by the way. So inequalities are widening, and there's a lot of interest in finding out what is the cost of disability, the cost of chronic diseases by different groups, and education is one of the ones that we are able to document very well. We also, because we know, again, how educated the future cohorts are coming up, then we can predict what will be the cost of disability and the cost of, say, cognitive impairment for the future generations. All right, so I'm gonna and by talking to you about this study and what place it has for studying aging in the world. So it turns out that back then in the 90s, we were one of the first studies that came up. And the first study that's similar to this is in the US, is the Health and Retirement Study. And that came up in 1992. And they have been following the cohort of 50 years and older and adding new sample every 2 years. But of course, the US is a rich country. MHAS, the Mexican Health and Aging Study, started in 2001. It was the first study that started, and we modeled it after the Health and Retirement Study. After that, the Puerto Rico study came up in 2002, and the British study, ELSA, started in 2002. ELSA has continued every 2 years, and they are very coordinated with the HRS in the US. SHARE is a similar study that was started in 2004 and in Europe, and now is done in 20 countries in Europe. Very similar, Costa Rica. You heard the speaker a couple of weeks ago, or was it last week? Last week. Costa Rica, he talked about the study of CRELIS. They started in 2005, Korea in 2006, Japan in 2007, Indonesia also. TILDA is Ireland in 2010. Very important, China was added in 2011 because of the size is very important, and also very important because of size of the country. India started in 2012. Brazil is the other Latin American country that's planned to do their study in 2014. And so we are in a network of about 30 plus studies that are working coordinated in how we study aging in the world. And the conception, the idea of NIH, which is they are the ones who fund our meetings to come together, is that we can study and learn about the aging process of societies and the world, how people age under different circumstances like the one I talked to you about, Mexico. Different childhood, different socioeconomic, different health insurance, and what determines how people end up and how successful aging can be. We have dissemination of the MHAS, the data that we collect because it's collected with your and mine tax dollars. They are public use. They are funded by the NIH. And also we have co-funding from Mexico, but everybody agrees the data should be available to the community, to researchers who want to use the data. And our promise is that we upload the data 9 months after the fieldwork takes place. And like I said, the fieldwork takes place in 3 months. So in conclusion, just wanted to close by saying, I told you at the beginning that it was important to study Mexico. Now we can study it with longitudinal data, which is important for aging of the Mexicans, but also to understand aging of the US Hispanics. Now we can study aging trajectories like the ones I showed you, mortality, and we can then now project the future needs of the societies that are aging under very different circumstances, and also the long-term consequences of migration. And now we're moving into make a lot of cross-national comparisons to study, like I said, human aging. So for example, with Luis Rosero, who came out last week, we're launching a couple of projects to look at differences in how educated and uneducated people age in Mexico versus Costa Rica. Again, Costa Rica, very equal society versus Mexico, very unequal. So this is where the website is, where we have the data and all the information, publications, and so on that have been done with the study. And I always like to share, this is where we keep track of the visitors to our website. I know many can be hackers, I don't know, but many of them are from different countries, and this is where the visitors to our website come from. Lots from Mexico and the US, but lots from Europe, India, China, South America, people in Australia, and so in Africa. And this is it. Thank you very much, and I thank our collaborators.